Daratumumab, anti-CD38, has become a standard of treatment. So in my practice, all newly presenting cases have this as part of their treatment as part of a 4-drug regimen. It's highly active. People go into deep responses and they stay in those responses for a prolonged period of time. The question is, how do you manage those people at relapse? So if you're in remission for many years, you may not need to change the treatment and you could use an anti-CD38 antibody again at first relapse. But after a while, I agree that if you've seen a lot of prior anti-CD38, you can become resistant to it. The important thing to note is that we're starting to have this option of bispecific antibodies and ADCs. So if you can target BCMA on the cell surface, you can get really good responses. And so the one drug, Belantamab Mafodotin, delivers to BCMA. It carries a warhead that delivers this toxin into the cancer cells, and that gives good responses. It's well tolerated, and it's a rather easy drug to deliver, despite it having a sort of itchy eye signal. Perhaps that's the best way to describe it, but that's become increasingly manageable. The other drugs, the bispecifics, are highly active and they fix T cells to the cancer cells. Maybe they have a greater response rate than Belantamab, but they're also more complex to use. So maybe they're more difficult to give to the frailer, older patient because of this cytokine release syndrome and ICANS where people get confused. And so we're in this process of trying to work out for relapsed resistant cases, which is the best way forward in terms of targeted monoclonal antibodies and CAR T therapy. It's a very exciting time for patients because these are highly active drugs, and I think they really do deliver us the potential for cure.